share it on Workplace. At the end of the meeting, we'll post a brief poll. We want these webinars to meet your needs, and your input is very critical. So we'd love you to fill out that poll. While our presenter is speaking, we'll have the lines muted to reduce unnecessary noise, but we will unmute you at the end of the presentation for questions and comments. And please feel free, as always, to enter questions into the chat box throughout the presentation. So I think it's time to begin, and I'm going to turn it over to my colleague, Dr. Lisa Letourneau.
Great, thanks, Kelly. Thanks everyone for joining us today. We're really pleased to have you here in our regular webinar series at Choosing Wisely. So I'm very pleased to introduce Dr. Brian Southwell. Dr. Southwell is the Senior Director of Science in the Public Sphere program in the Center for Communication Science at RTI International, which is an independent nonprofit research institute. He also holds faculty appointments at the University of North Carolina at Chapel Hill and at Duke University. Additionally, he hosts a public radio show called The Measure of Everyday Life for WNCU and holds a doctorate in communication from the University of Pennsylvania. We're really pleased to have Brian join us today on this very intriguing topic. And we'll turn it over to him, how to help patients who encounter misinformation.
Thank you so much, Lisa. Thank you, Kelly. Thank you, Kate, and others who made this possible. I really appreciate the chance to talk with you all today. I think there's tremendous synergy between some of the work that we've been doing and the general emphasis of both this webinar series and the Choosing Wisely campaign overall. So I'm going to go ahead and share my screen here. And hopefully everybody's able to see that just fine. In a lot of ways, the conversation that we're going to have today is going to be a natural extension, I think, of some of the consideration that you've had, in this webinar series. It's also, for me, another step in a journey that I've been on for a while in terms of thinking about misinformation more broadly as an academic concern. And in the last few years, actually for a number of years, I've been working on different studies for the federal government and for other partners, thinking about how it is that we might actually both keep track of and mitigate misinformation in the realm of medicine and health. And that general journey has suggested that we ultimately need to not necessarily think about just stamping out misinformation wherever it lies, but instead to think about ways that we might actually build relationships with the people that we're trying to help, that we're trying to bring into the fold in terms of behavior that we want to encourage. Certainly, when you think about some of the work that the Choosing Wisely campaign has engaged with in trying to avoid unnecessary procedures, misperceptions, misinformation are an important part of the equation. It's also the case that you've emphasized in that effort, trusting relationships between clinicians and their patients. And you're going to see that ultimately is a remedy that we think is important more broadly when it comes to the question of misinformation, what we might do about it. And so what I want to emphasize here, and one of the takeaway messages, is that ultimately I think we need to focus less on actually blaming people who don't trust the formal messages that we have to put out there, and instead I need to focus more on actually building trust and maintaining trust in the first place. So a talk about misinformation is ultimately going to lead us to thinking about trust and relationship building. So I want to take you on some of the steps along the way that have gotten us to that point. I think when it comes to trying to generate remedy for this problem, we've really got to spend more time asking about what information people are seeking and searching for on their own, and what information people accept. And that's a different orientation than just simply understanding what's out there, in the environment, and certainly a different orientation than just simply tracking what it is that we broadcast in the first place. So rather than just paying attention to messages and information that we are circulating, rather than bemoaning every piece of misinformation that you can find on some dark corner of the internet, instead, I think we need to spend more time thinking about the information that's actually crucial and important to people. What is it that's important to them as they're trying to live their everyday lives? And along the way, what sources do they turn to for trusted information? What do they tend to accept? What can we learn about that? So ultimately, we need to ask questions about what it is that we actually mean by this notion of trust. And trust is a multifaceted concept. It gets used in colloquial ways, in all sorts of different ways. And I think it's important for our discussion, though, to recognize at least a couple of those dimensions, one of which I think doesn't get nearly enough emphasis. So if we ask the question, what is trust? There are at least three different ideas that we might raise that are interrelated. Certainly the notion of credibility is the way that phrase often gets used. And we might also think about reliability in terms of the dependability or the consistency with which people are, or what we come to depend on in terms of information people are putting out. But the perception of shared interest is an aspect of trust that I think is crucial. It's important. I think it explains a lot of behavior, a lot of information behavior. And yet we don't necessarily spend enough time actually considering that. And so this is different than me having a sense that you might actually know what you're talking about, or me having a sense that you're often going to say the same thing if I come back to you 2 or 3 times. Instead, it might also matter that I think you and I share some mutual interest, here in this dilemma that we're talking about. Because otherwise, you might be perfectly credible, or you might be perfectly dependable, but yet you might not actually see my interest as being the same as yours, and so you might actually, be looking to trick me, or you might actually not be emphasizing the certain dimensions of information that I think are important. So shared interest and how it is we might both identify shared interest and communicate shared interest, I think is an important piece for many different to think about in reaching different audiences. So what is it that we can do? I want to emphasize here a few ideas built on some recent years of experience in terms of initiatives and different projects that I think might hold some import for a lot of the work that you all are doing. I'm going to emphasize some general themes that have emerged from those. And then I want to walk us through specifically an initiative that I think is directly pertinent to a lot of the work that you all are conducting on a regular basis. So, short story here with regards to all these initiatives is that I think there are really 3 main themes that we need to emphasize. And they're common sense, but they're often overlooked. And they're not often baked into a lot of the initiatives that organizations put together. So in short, I think we need to encourage compassion. Compassion maybe even being something slightly distinct from empathy, although it's related. Empathy can be draining, though, if you're constantly feeling what others feel. But at the very least, you need to be having compassion for their situation. And I think that that's going to be an important part of the conversations between clinicians and their patients that might get to a spot of asking different and more important questions rather than just emphasizing what's wrong about what a patient is pointing out when it comes to a piece of misinformation. We need to do a better job of actually learning what people are encountering. And that means actually perhaps holding our nose a bit and understanding all the different information sources that they're using in their everyday life, even if they're not peer reviewed, even if they're not what we might deem to be most important. It doesn't mean ultimately we can't try to steer people towards credible sources, but we first need to start by understanding where is it that people are turning to for information. And third, I think we need to do a better job of empowering people themselves and improving their own information seeking abilities. There's been a lot of really interesting work to suggest that actually if we can just encourage people to spend a bit more time actually double and triple checking what they find on the internet, that can go a long way. It's not going to eliminate all of the concern, but actually having people pause for just a moment before sharing something on Facebook, pause for just a moment before running to their clinician with something they found on the internet, that can help quite a bit. So I want to talk about a few initiatives that have all emphasized, in one way or another, some of these themes. The first actually was part of a discussion that I got involved with in Europe a while back, and I had an opportunity to put a workshop and a training together for an organization called Excite. Excite is the European consortium of science museum professionals. And science museum professionals, by and large, the discussion we had leading up to this workshop, there's a lot of consternation about all the unscientific places people are turning to for information and how it is that that's a travesty. And in fact, what we ended up emphasizing in this workshop is neatly, suggested by simply what we did in moving and iterating and evolving the title. Initially, when I was asked to go over and to Copenhagen and be a part of this, the initiative, what they had in mind was a workshop that was going to emphasize combating misinformation. So a real war metaphor. And ultimately, what I encourage them to think about here is to move beyond not only the war metaphor, but even beyond fact-checking. Fact-checking initiatives are really popular, and they're important, and that's a lot of what you're going to find in the misinformation arena has to do with formal fact-checking arena initiatives. This is particularly true in the political context. But I think we need to move beyond that. I think that we need to actually think about the relationships that we hold with audiences, with clientele, with residents in particular areas. And that's actually what we ended up emphasizing in the case of the science museums, was for them to think about themselves as community partners, rather than necessarily just the trusted or the authority on your particular pieces of information. Similarly, back in the summer of 2019, I was able to organize a forum that the ABAM Foundation, fortunately, Daniel was able to be a part of, and we really appreciated their contribution there. We put together a meeting to ask the question, what is it that nonprofits and foundations might do when it comes to the concern about trust in science. Here in the United States, there's been a lot of concern that trust has eroded in important ways. As it turns out, that's true. It's also, there are and continue to be important repositories of trust. So I think it's going to be important for us to not only think about completely building or rebuilding trust, but also maintaining trust where it does lie. And I think trust in one's own clinician is an important source here that we want to be careful not to overlook. But this discussion was a fascinating one. We actually put people into teams to work on a series of ideas and initiatives and problems that had been nominated before the event. And in coming together, we asked people about some of their own lessons learned when it comes to building trust in science. And there were 4 suggestions that emerged that I think are relevant for our discussion here today. Again, these are straightforward, but this is, these are important minds at different organizations thinking about what is it that needs to be done, and they emphasize these things over and over again. The first was really moving towards a sense of open science, and what they mean by that is transparency, not necessarily a free-for-all, but really trying to make the work that happens in peer review more open and transparent for various audiences. It's also the case that people recognize that they're not going to be able to completely control the information landscape, that they're going to have to equip audiences themselves for critical inquiry and information search. Scientists are part of this equation, not all of it, but part of the equation, and we need to do work to train them to become better communicators. And ultimately, we're going to need organizational collaboration. This is an area I often firmly believe in organizational collaboration, but in this area in particular, we really need cross-sectoral collaboration. We need to have collaboration between scientific institutions and media outlets and government institutions, and this is not collaboration that's happened to date, but we're going to need it. And I think that's work that we can get started on. But many of you are here on the call today for us to think about the specific situation of healthcare professionals and the challenges that they face in talking with patients about instances of misinformation. And so just to set the stage, here in North Carolina, in this past year, we have tried to look at this as an empirical question, to understand, is it the case that clinicians actually see this as a dilemma that, anecdotally anyway, that we've been hearing? And we've got some evidence to suggest that that is the case. We actually finished up a survey in May 2020, despite the early months of the pandemic, with North Carolina clinicians. We worked with the North Carolina Medical Board, and we surveyed almost 3,000 participants, about 2,200 of which informed, we're currently licensed and eligible. And of those folks, a large percentage not only actually had experienced misinformation recently in the context of a patient exchange. In fact, almost 95% had. But many of them suggested they hadn't actually ever received any kind of training as to what to do about that. Jamie Wood, my collaborator at Duke University, and I actually have a paper under review with the survey data. And not only do we find almost universal experience with this information, but we find less than a fifth of people have ever had any kind of training or workshop or any effort to help them deal with this situation when it comes to patients. So we actually had hundreds of people wanting to know more about a workshop. And that was something that was encouraging. We actually have developed a pilot workshop, and I'm going to talk to you a little bit about that now here. So with gracious support from the ABIM Foundation and also Craig Newmark Philanthropies, we put together a pilot workshop that we held at Duke with clinicians, really focused in on not only helping people understand why it is that patients might actually both encounter misinformation and believe it, but what is it that could be done about it in the context of a time-constrained visit? What kind of conversation can you have with a patient? Building on that pilot experience, we then directed a video that I'm actually going to share with you here. It's about eight and a half minutes long, featuring Anne-Marie Navarre, who's a cardiologist and a colleague of mine. And the video, in a lot of ways, hits some of the highlights that I'm going to then unpack in the few minutes after that, and then turn the stage to some questions. But let's go ahead first here. You're going to hear Anne-Marie in this video, offering some of the highlights and some of the points of emphasis that we raised in the workshop.
Hi, my name is Anne-Marie Navarre, and I'm a cardiologist. For those of us who regularly see patients, one of the more challenging situations that we face happens when we realize one of our patients has found some inaccurate information and they want to talk about it with us. Maybe they read about a new treatment on the internet, or their coworker told them about a new virus. Your first instinct when encountering our patient's misinformation may be frustration, or you may want to just dismiss it out of hand. But how we handle patient information and misinformation can set the stage for future interactions and trust. The good news is that if we take some time to understand why patients sometimes bring misinformation into the exam room, we can improve how our organization and ourselves can address misinformation in the long run. The first step we need to take is to understand why health and medical misinformation is such a concern. Despite the efforts by technology companies to address medical misinformation, it's still really easy for anybody with an internet or cell connection to find inaccurate medical information online. Sometimes patients are drawn in by messages of hope and well-being that charismatic actors offer as they try to sell natural or alternative products. This happened in Australia when a young woman named Belle Gibson rose to fame based on fraudulent claims about her efforts to overcome a cancer that she never had. Sometimes people encounter a comment or a claim by a friend or a family member, either on social media, in a text message, or perhaps at the kitchen table. It's important to keep in mind that there are reasons why medical misinformation is a persistent problem for us and for our patients. Researchers have pointed out why we can expect patients to be challenged by misinformation that they encounter. Psychology research tells us that people tend to accept misinformation at face value and only later determine it to be false or true. People don't just ignore false information. In other words, they take in all the information that's presented to them, and only if they have time and ability, they later determine whether it's false or not. The problem is they just don't always have that time. We talk with each other for lots of reasons, and not just because we're trying to pass along facts per se. Think about the polite conversation you have when you see someone in the hallway. We don't just pass facts back and forth with family, friends, or coworkers. We interact with them because we want to signal our relationships with them. Regulation of media systems in places like the United States mostly focuses on post hoc detection of false claims, rather than preventing those claims from ever appearing in the first place. That means that misinformation often appears on the airways or online, and only after are we able to combat the impacts of said misinformation. As clinicians, correcting misperceptions that our patients have about their health is not only possible, it's extremely important. But it can be difficult, and it requires educational resources. When we consider these factors, it becomes easier to understand why a patient might show up with a problematic printout from the internet or a story about their health that they were emailed from their cousin. What can we do to improve our encounters with our patients? Well, let's think about that situation when a patient shows up in your office and they've been inspired by misinformation that they found or received. First, don't immediately focus on discrediting the source of what the patient is saying. Time is valuable, and it doesn't make sense to spend time trying to undermine a third party when there are actually more important aspects of your conversation. Avoid using technical jargon and pointing out why the patient is wrong. Explaining to a patient that a study is hopelessly confounded isn't going to help you. Rather, explain to the patient in terms that they can understand if there are problems with the study that they bring, and focus on the information that you do know. Next, don't emphasize that the patient was wrong or mistaken in believing the misinformation they were presented. It's important to avoid a tone that belittles the patient. Be careful not to overstate your own certainty in the corrective information that you might have to offer. Show care and openness with your body language as you speak with your patients. Ask them what they've learned about a treatment or a topic. Ask what about the belief or claim that the patient is introducing is personally important to them so that you can understand their values. Listen and acknowledge that you understand at least a part of what the patient is saying. Ask if the patient would be interested in additional information. And finally, refer them to easily accessible and credible information sources so they can continue on their own path to self-education. Sometimes patients recognize that they shouldn't believe everything they read or see on the internet, but they have trouble knowing what they should or shouldn't trust. If they ask you about that, encourage them always to consult sources like your own organization or trusted organizations of professional societies. We can't train people to avoid false information completely in a single conversation, but we can encourage our patients to look for the source or sponsor of information and to consider that source. Beyond questions you can ask about how you can improve your own interactions with patients, we also think about ways that the organizations in which we work can help. Any one of us who sees patients knows there is never enough time, and there isn't a lot of time available for a lengthy conversation about a single topic in any one visit. There are limits to what any one of us can do to address misinformation in an office visit. Our organizations can be working with patient communities to offer additional resources. Consider these questions and ideas. Does your organization post a frequently asked questions site on your organizational webpage? If so, does that site reflect recently submitted questions or concerns from those patients? How does your organization collect questions or concerns about medical information from patients outside of clinical encounters? There are helpful initiatives we can develop and implement if we start from an understanding of patients as generally well-intentioned people looking for hope regarding their own health and the health of their loved ones. It is easy to find misinformation online, and it's understandable that patients encounter misinformation regularly. We can improve the way we work with our patients. No matter what help we offer, patients will continue to seek medical advice from the internet, peers, and family members. What we need to do is walk alongside our patients, listen to what they're saying about their values and preferences, and offer credible resources to guide their decision-making. Together, we can build trust and relationships that can help as we navigate the information landscape of the 21st century with our patients.
Great. Okay, let me go back here and make sure that we're still sharing. Are you able to see my screen again? Hold on a second.
Yes.
Okay, we're back on, back up. Okay. All right. Sure that's up. So a nice summary of a number of different ideas. I want to pull out a few of those for our consideration here today, and thinking about that. The first is just this point of emphasis that's surprising, but I think important for a lot of the discussions that we're going to have with patients. Just the recognition that actually all of us are vulnerable to misinformation, at some point in our lives under the right circumstances. Empathy and compassion are going to be key, here moving forward to whatever we develop in terms of future intervention. I also think that the example of Belle Gibson, that we highlight in the video is crucial, because the Belle Gibson story, doesn't just suggest a problem in Australia; it suggests a problem worldwide. And it suggests that actually we're all part of the situation whereby misinformation proliferates. Belle Gibson wouldn't have risen to fame if there wasn't an audience for what it was that she was emphasizing, and she was emphasizing hope, and she was emphasizing hope against a really discouraging and tragic disease. Now there are important ethical problems with her fraudulence, but that's different than the recognition that actually we're all part of the audience for that kind of information sometimes. I think ultimately it's important that we recognize that we conceivably misunderstand our own vulnerabilities. I think, and it's maybe less difficult to emphasize that these days, there are a couple of major ideas that we might think about here. First, we all need social connection. We've learned that in the last couple of months more than ever. We also need hope for the future, and we've learned that as well. And when we're missing either of those, that actually is an important warning sign. It's a recipe for the diffusion of misinformation, particularly if that misinformation offers any kind of salve. And we see that happen time and again. It's not as though people are necessarily buying into ridiculous information just for the heck of it. They often are looking for ways to keep their family healthy. They're desperate for ways to keep their family healthy. And they're also looking for ways to stay connected with others that are like them in their community. And so we see, this reach out, this effort to look for information that's going to provide some sense of hope, and then the ready sharing of that in an effort to try to connect with other people. And so it's not necessarily the willful spread of misinformation in all cases. We know that politically, some of that happens sometimes, but for the most part, I think we've got is a situation where people are sharing this kind of information because they're excited about it. And they think that it actually offers some remedy to what's been a really difficult and threatening problem or situation. And so thinking about the psychology of misinformation diffusion, I think is really important. And it makes it more understandable that somebody might have gotten information from their uncle or their friend passed along to them on social media. So with all that in mind, I know that these discussions are often an opportunity for exchange as well. I wanted to open the floor here to see if any of this resonates and to hear a little bit about what some of your experiences have been. I think there are a couple of different ways that we might be able to encourage that kind of discussion. If you've got ideas or examples, you can put them in the chat. But I also know that Kelly and the team have talked about this a little bit internally as well, and I think might have some examples for us to talk about and to unpack and to think about as hypothetical situations that we might need to address. Lisa or Kelly, here, let's turn the discussion to everybody, but some examples of anecdotes that people have encountered in terms of clinician experience with misinformation.
Great, thanks, Brian. Well, that was fantastic, and the video as well, I think, was very helpful. So thanks for sharing your thoughts and that as well. And yeah, I think that's a great idea. If anybody has examples, I suspect clinicians on the line and others, whether through friends or family experience, have probably encountered pretty clear examples of misinformation that you've encountered.
One note, we got a comment in here about Gary Schweitzer's work. And Gary's actually an old colleague of mine. We both taught at the University of Minnesota for a number of years, and I've had him on the public radio show that I host, and yeah, I would recommend his work as well. He does this health news review has been a good monitor of the health information environment, the health news environment, and he tends to call journalists out for problematic coverage in different circumstances. So thank you, Bill, for that recommendation.
And Bill, you're not usually shy. Bill Adams is a longtime friend of ours. If you want to unmute and or put your video, I can't all see all the squares right now, but come back on video. I know you were on it earlier. If there are any specific examples, either from there, or Bill also does the baby boomers for healthcare. Bill, I'm forgetting the name of it. Balanced, thank you. Thank you, Kelly. And so I would expect you have a lot of opportunity for conversations with older adults around some of their beliefs as well. So anything you want to share specifically, Bill, as an example? Since you were brave enough to chat a comment.
No, I don't have anything specific, but I think Gary Schweitzer's work is so good because it highlights the difficulty that people have in getting really good information, even from reliable news sources.
Yeah. So, Bill, you raise a really good and important point here, which is, thinking, and we've got, we'll go to Janice here in just one second, but just a comment. When we think about the misinformation landscape, we think about the information landscape. It's easy. I think a lot of us, have a sense that, you're talking about some really problematic, corner of the internet, somewhere, something that somebody's come up and dreamed up, on their laptop, sitting on a couch.
2020 year brings you lots of opportunities. Remember, CS.
And I'm not sure. Was somebody trying to come in with a comment there?
I think maybe it was a slip of the.
Okay.
Yeah.
Yep. So, but I think it's crucial that we realize that there are all kinds of sources of error and noise and misinformation, and that some of that comes in problematic journalism, as well. Some of it is, willfully, produced, websites that are peddling really problematic and misinformation or problematic information. But there's a lot of other instances where, more, conventional sources also sometimes can lead to some of the noise. That's actually part of the reason why we use the term misinformation and not some of the other alternative terms that you hear sometimes, because misinformation is an umbrella. And it allows for us to think about, some of the noise that's out there, even aside from willful intent. You'll sometimes hear the term disinformation as well, and that usually refers to instances where people are actively planning to sow the seeds of deceit. And then there's another phrase with an F and an N in it that you're not going to hear me utter. And there's specific reasons for that, because I think it's actually would be better for all of us to not use that term, because it's actually a political term that has served to undermine journalism in important ways. And I think the real story is the inaccurate information that's out there sometimes we all have to deal with, and not necessarily capital N news per se. And so, but yeah, it looked like Janice had a comment. Was that right? Or at least
yeah, thank you for what you were sharing earlier, and I appreciate the video. I just want to say that I'm actually, I guess, a product out of misinformation. My mother took diethylstilbestrol when she was pregnant with me for, to supposedly prevent miscarriage. And so a lot of us were greatly affected by that as we grew up once we reached puberty, but it was prevailing at the time. That's what it would help, just like thalidomide and sedatives. I mean, this is throughout medical history. And I've been more recently involved with research as a patient. I'm a PCORI ambassador. I've been involved in multiple research projects, quality improvement. I'm involved with Choosing Wisely. And I think that one of the brightest things I could say to anybody is, the more I learn, the more I realize I don't know. I mean, the more, and what really works for one person doesn't work for another. And if a clinician isn't able to, really convey that when they even prescribe a medication, then that's an issue. I'll give you a perfect example on that is I've taken Zofran for nausea, and I used to think it was like a miracle drug. Everybody I knew that took it, it really helped. And then a friend of mine took it and had a very severe side effect and ended up in the hospital from it, right? So she was just prescribed it for nausea, but, not many of us actually read what the side effects are. And so on that same line of misinformation, I do know, working with guidelines and measurements and such, and even in research, that a lot of this, a number of side effects do not get in or even listed because there's not enough individuals that stated they had them, and they only pick a certain percentage of them to list. And so really anything is a risk, and it's something we have to remember. So I appreciate your misinformation. It's a very good term. And during this time of COVID, I think there's almost more misinformation. I know there's more misinformation than fact out there, journalism and otherwise.
Yeah, no, I thank you, Janice, for all that. Your comments, suggest a number of things, but 2 points, there. One, for folks that think that this is just a mundane topic, we know, that unfortunately, misinformation can have really deadly consequences sometimes. We certainly are seeing that with, suggestions to drink bleach or to, other things like that during the COVID-19, pandemic. And we've got to pay attention to it. It can have serious consequence. And in fact, we probably need to prioritize certain types of misinformation over others. I think that there's all kinds of silly examples you can find, on the internet. And that's different than suggesting that we have to necessarily worry about everything that's out there. I think we probably need to prioritize that which is life and death, that which is going to cause public health harm, and that's an organizational priority, a prioritization that needs to happen. I think that rather than just bemoaning any piece of information, misinformation that's out there, we probably need to together make a concerted effort to say, what are the things that are going to cause real harm for people? What are the real behavioral consequences in terms of harm, and to focus on those first. Okay. It sounds like we've got or it looks like we've got a comment here from Yale, and great. So thank you for raising those examples here. Just to paraphrase for others that aren't reading the chat, you noted that there's been, that you're an internist and a hospitalist, and that there's been a lot of examples of misinformation regarding both COVID and vaccinations, natural supplements, utility of testing, and that people are finding this on the internet and the news, but also even from other providers. And this is part of the reason for the tone of compassion that I think we need to enter into these conversations with, is that some of the conversations you may have, it's conceivable you'd have a conversation like that with a colleague, too. But I think that ultimately, and this goes back to Janice's earlier point, we don't think, my colleagues and I generally don't think that we have a one-size-fits-all single tool that's going to eradicate misinformation from the patient information landscape. Instead, what we want to do is encourage the basis and foundation for clinician and patient conversations in an ongoing way. We know that time constraints make that difficult, but we ultimately think here that this kind of tone and approach is going to be more likely to be the foundation for later conversations about what it is that ought to be done in adjusting treatment or in making decisions together. And I know that's an old notion of shared decision making and all that, but at the same time, it's important for us. And I think that it's easy for us to sort of overlook that in really important ways. The COVID-19 situation has brought a flurry of lots of different dramatic examples. But something I want to point out, and this might resonate with all of you that work in a clinical setting. You might think that you've got a really serious problem with misinformation amongst your patients, because in the last week, you've heard 2 or 3 anecdotes that really troubled you about instances where patients came in and they talked to you about misinformation that they found. I want to argue that actually you're in much better shape than a lot of your other colleagues. And that's because you're actually hearing about the misinformation from patients, which means that you have enough of a relationship that you are actually hearing from them. And we think that generally speaking, that's a good place to be in. If we can be having dialogue and conversation, that's better than never hearing it at all and having people either not engage with the healthcare system or to only be doing that in an adversarial way or to be coming in for their visit and then off having other conversations somewhere else. So the closer that we can get to actually monitoring, understanding what information is influencing people, the better. And it's a good sign. I think it's a sign of the relationship that you've built that you've heard some of these examples. Okay, so here I'm actually going to move to another screen. I want the other examples to continue to come in if people have other ideas, but I just in the interest of time, I also want to point to a couple of other resources. Some of you are aware of the ABIM's Foundation's efforts in a lot of different veins, and the Building Trust Initiative, which is a sister initiative in a lot of ways to Choosing Wisely, is up and running as well. And I have a blog post there that emphasizes trust that might be of some interest. So I put that URL on the screen as well for additional reading. And there are a number of other things I can share also, but I wanted to sort of put that out there. Let me also, though, draw from some personal experience here in terms of thinking about, thank you, Kelly. She's also noted that the blog post is on Workplace. So in thinking about some of the examples that that we can encounter, I do want to go back to that earlier notion, because there are all different types of misinformation that you might encounter. There might be misperceptions around cost. There might be concerns about actual consequence. There might be concerns people have prior to entering into a clinical trial. There might be things that people have heard about what's forthcoming and something that we don't necessarily know yet in terms of new peer-reviewed science. And it's nice to be able to package all this together sort of in one conversation here as we think about misinformation. But actually, there's enough of diversity in terms of the types of situations you might encounter that I think it's worthwhile for you to adopt and to think about this as a stance or a perspective that you might have for patient interaction sort of in general, rather than thinking that there's one type of frequent myth or misperception that you can deal with, on the frequently asked questions section of your, organization's webpage. Instead, I think it's really a matter of orienting yourself towards, trying to understand what's at the root of people's, misperception, and from that perspective, we know that sometimes the actual problem lies in, an inaccurate piece of information that's out there. Sometimes it lies in how people have interpreted it, how it is that people have, they've looked at and scanned a headline and they've gotten the wrong perception, from that, or they've tried to make some effort on their own to look at peer-reviewed science and they haven't necessarily interpreted, statistics, in the right way. And so again, all this is going to mean really trying to get at the root of what it is that people are feeling a sense of urgency in talking to you about. What is it they're trying to accomplish in raising this concern about this side effect, or in raising this concern about the need, that their urgent sense of need to be tested for something that you in your own sense don't think they need to be tested for. What is the value that they're expressing? What is it that what's the problem they're trying to accomplish or that they're trying to address? And that's surprisingly not something that happens as often as it should in terms of these exchanges. We'll see an instance where a conversation will go off the rails because somebody either dismisses out of hand a ridiculous piece of misinformation, or they get offended by it. And then that sets the wrong tone when in fact the conversation that could have happened would be more along the lines of really trying to understand where somebody's coming from and what is it trying to get at by raising this idea about this natural supplement, or by suggesting this is an alternative to going on or not going on medication. What is it that they're actually trying to express to you there? So it's really in some ways goes back to, I think, what's at the heart of many of your interactions of trying to understand people holistically and try to understand our patients holistically. And I think this is an important part of that as well. So I also then, if we've got time, I just want to suggest, together we are on the beginning of a larger journey as well. As we think about, this clinician workshop, we think that actually this is a scalable idea, that this is something that we could be doing in partnership, with organizations, around the country. And we've started a number of conversations, we've got additional pilots in the works in the Tufts, system, for example, up in Massachusetts and out in California. And maybe some of you on the phone would like to have that conversation about what is we might be able to do to bring this to your organization, in a way that would make it available for the staff, in your organization. We do view this as an approach that's emphasizing staff training, and it's emphasizing clinicians as an audience, rather than patients themselves. And we think that that's a place to start, and we think that it's crucial and necessary. So, okay, so with that, I'm going to maybe broaden us back out to questions that people might have here in the last few minutes. I'm happy to talk about any of the dimensions of what we've done here, or about some of the academic work we've done in writing and research we've done on correcting misinformation. It's all fair game.
Oh, sorry. I have a, from our patient focus groups, one of the major things was natural things, but I think we've covered that a lot. The other major thing that, particularly with Choosing Wisely and trust, that we heard from patients when we did our focus groups was many of the patients had a deep-seated belief that treatments and procedures were being recommended because there was personal financial gain and conflicts of interest. And that is something that I don't think would necessarily come up in the clinical conversation, but certainly affects the relationship. So I'd love to hear your thoughts on that.
That's great. So yeah, so you might think about how is it that you could get to a point where that that could be talked about, and it may be a matter of actually laying some cards on the table and actually opening up that conversation in ways that isn't always comfortable. But Kelly, what I love about that example is it's one that absolutely could be driving patient behavior, certainly affecting patient perceptions, and yet it would be very awkward or uncomfortable to directly accuse, for example, a clinician of having a profit motive, or to be thinking about this from an organizational standpoint. And that's where I think that actually transparency and kind of going back to that earlier theme can help. And it's systems are set up in particular ways. There is a funding arrangement. There is a financial model, and I think that we don't have to pretend that that's not part of the equation of how organizations are run under certain circumstances. But so I think opening the door, and actually a little bit of that goes a long way. To kind of point out that yes, in fact, X and Y is a pathway through which this organization, makes money, and is funded and is financially, feasible. But at the same time, rest assured, we don't have, you can address this as a concern. We've heard this is out there, and want to point out that this is not necessarily a concern. You could also imagine instances where not all this is happening in the examination room or online, as a clinician and a patient, talk to one another. And this is actually a reason why organizations and foundations also can engage in concerted public communication campaigns. I think only emphasizing, what's wrong about what you've heard about, financial motives, that might be a difficult place to start because it might seem defensive. But I do think it could be part of a theme, especially once you've gotten to a spot of emphasizing some of the points of shared interest. So that goes back to the earlier notion. I think ultimately we've got to point out the reasons why an organization cares if you live or die. The reasons why a healthcare organization related in some way to healthcare cares about your individual health. And some of it is for the greater good and just collective well-being, but some of it actually matters in terms of bottom line too. And I think that there's ways that could be pointed out that might not be obvious to people. It's in everybody's interest to have societal stability, and well-being in different ways. And I think being a little bit more transparent about that, just even as a political or a governance issue or as a societal stability issue, that might help, as well, Kelly, to kind of point that out. But I like that as an example because there are a lot of instances where really important misperceptions arise from that. And it's also part of the foundation for a lot of the conspiratorial thinking and that's out there. And we haven't talked too much about that, but there's a conversation to be had as well about both belief in conspiracy theories and that general genre of videos and memes and other content that circulates on social media. And I guess my one takeaway on that would be to suggest that even if something's nefariously put together, from a motive standpoint, people that buy into and believe it, it's not always a completely lost, cause and situation. I tend to have belief in people, generally, as wanting to maintain their own health and well-being in some way. And if you believe that we at least have that in common with some of the folks who are adherents of conspiracy theories, that gets you to a better spot of realizing that we at least have that in common. So, and I think that's important. But Kelly, I appreciate raising that example. Other, yes. So we've got a question here about information in terms of options. Yael, I've got my email address, I think, is still up on the screen. I'm going to put that in the chat as well. And I would be happy to share outline of what we've done in terms of practical logistics, for different possibilities. I should point out that I jointly hold appointments at RTI International and Duke University, where we've been developing this work from both Duke's perspective and RTI's perspective as a nonprofit research institute. We view ultimately the workshop as a service that we want to provide to society, something that will benefit from financial support, but that we don't view as just a money-making endeavor. That we actually are interested in trying to find ways to provide this as a subsidized service, for the various members of healthcare organizations. So we've talked, for example, here in North Carolina, we're talking with a rural county. An area foundation in that rural county is interested in bringing us in to provide the workshop for 40 or 50 of the staff at their healthcare organization. So it's free of charge to the staff, and the foundation would be providing a small award in order to make that happen. So, yep. So I'm happy to, I don't know, how are we on time? Kelly, we have time maybe for one more question if
Maybe
there is one?
yeah, we've got about 5 minutes left. So
okay.
If there's one more question, we certainly can take it.
Okay.
So I have one more. Speaking of COVID and the comment, I don't want to jump. If anybody else has one, I'll pause. But I've just been dying to ask this one.
Okay.
Well, particularly around COVID and the disparities that we know, racial, ethnic disparities, and the very well, earned sounds like a good thing, but the well understood mistrust of the healthcare system. And a lot of misinformation that's out there, particularly prominent in some diverse communities. Do you have any particular advice around? I'm sure many of the same themes, would echo, but anything?
Yeah, no, I appreciate you raising that, because this is a serious concern for us. I've done some work at RTI on, we just did a national survey on perceptions related to COVID-19. One of the modules we had was focused on vaccination. and potential hypothetical interest in and acceptance and openness to vaccination if it comes.
Mm-hmm.
And we found some important differences based on race and based on education in ways that would be problematic, because some of the same groups that are really at risk or, given current circumstances, for COVID-19 complications, are also some of the same groups that are expressing some hesitancy with regards to vaccination. And I think here, and this is something I actually was quoted in STAT a couple weeks ago, emphasizing this, and I think we've got to be transparent and realistic about like what some of the likely side effects are going to be. For example, with vaccination, there's a good chance that if some of the leading contenders are not going to feel particularly good for people for 24 hours afterwards, but it's going to be better than actually coming down with COVID-19 or spreading it. But being transparent about that, being careful not to use language around miracle and breakthrough, but rather kind of pointing out where we are. And I think starting conversations now, part of the problem with the situation where we are with the COVID-19 pandemic is that we're wanting to flip a switch and reach out to different communities and say, hey, come, we should sign up for this trial or be part of this. We should have been doing that 5 years ago. And so I think, unfortunately, some of the work that we're doing now is going to be beneficial for the next pandemic, 3 or 4 or 5, 10 years down the line. But it's going to be hard to sort of turn on a dime and have that be immediately helpful. So I think what we need to do is not be gearing up immediately for our targeted communication campaigns that we're going to roll out in the next 2 weeks, and to try to get different communities to test or to be vaccinated, even though there's an incredible urgency to that. But I think we need to spend a little bit of time listening and trying to invite different communities in to raise the questions that they have now about future vaccination, about and to help steer the ship. I think that's going to be important. And it's going to take a lot of effort, but I think it's something that we've got to look seriously at. What our leadership looks like in organizations. To what extent do we have liaisons to different communities? If we don't have that, we need to work on making those real built relationships, rather than assuming there's going to be a great brochure or public service announcement that's going to magically sort of reach a particular group. Because I think if we can find a way to point out some of the shared interests between our healthcare organization and this local community now, and to kind of cement that by actually bringing in community partners to be part of advisory boards or other things like that now, that's where I'd put a lot more of my emphasis at the moment. I know, Lisa, that works hard to do, and it's not quite as sensational as some of the off-the-shelf communication efforts, but I think that'll get us to a better spot ultimately. So I don't know, Lisa, what's your own take on that from a physician standpoint?
Well, I think, it's this tension between, I totally agree with you, it's not a quick fix. It's got to be a long-term commitment to long-term solutions. And yet we are in the face of this pandemic, and the last thing we would want would be to say, we can't get those numbers up somehow and have a second wave of disparities with vaccines. So I think, the same ideas that you're thinking about, transparency, what we do know about it, where, we're not that the vaccines are magical, but where they came from and what we realistically expect, and then trusted voices, I think, to the extent that we can, even if we don't have them right now, if we can somehow get them through partnership.
Yeah, and we do in some cases have more than we think. I mean, that's something by looking at different organizations. I've been really surprised. I know we're just about out of time, but there are a lot of people that have direct personal connections. People have lost, someone in the COVID-19 pandemic. There are a lot of, clinicians who have different backgrounds, that now is the time to have that open conversation to say, look, we don't want to draw on, you into this conversation simply because of that background, and yet you would be potentially a good liaison or spokesperson. Let's just talk about, what possibilities, exist there. Because I agree, that would be a good next step. But trust is the key. Relationships are key. We need to be working on this 24/7, and I think we'll get there together. But I really appreciate. I want to thank everybody. Thank the ABM Foundation for this opportunity to talk with you all. I'm a really big fan of the work of the Choosing Wisely campaign, and so Kelly and others, and Lisa, thank you so much for introducing me, and Kelly and Kate, thanks organizationally for putting this together.
Great. Well, thank you so much, Brian. That was fantastic. Kelly, anything in closing?
Yeah, just I want to echo my thanks. I want to point everybody to the poll. Let us know how you think we're doing. And remind everybody that next month we'll be discussing Delaware's statewide advanced planning Advanced Illness Planning Collaborative. So we'd love to see you again next month. But thank you everybody for joining us. Thank you again, Brian, for the really interesting and thought-provoking talk. And hopefully we'll see you all next month.
Great. Thanks
Take
so
care.
much.
Thank you. Bye.